All right. Hi, everyone. It is 12:01, so I think we'll go ahead and get started. It's good to see so many of you here. If more people trickle in later, we'll let them in afterward. I did want to let everyone know that this meeting is being recorded so that we can post it online later. But I mainly want to introduce our speaker and then hand the floor over. Today we have Dr. Tamika Zapolski, who is an associate professor in the Department of Psychiatry at Indiana University School of Medicine and Department of Psychology at Indiana University, Purdue University, Indianapolis. She's the director of the Prevention Research in Substance Use and Minority Health Lab, which examines individual, interpersonal, and sociocultural factors related to developmental risk for substance use and other health behaviors, particularly among minority populations. Dr. Zapolski is going to speak to us today about the current state of substance use among Black Americans and sociocultural factors for both understanding risk and protection for substance use within this community, as well as research and clinical implications of this body of work. And we are thrilled to have her with us, so I will give her the floor.
All right, thank you so much. So I'm here to talk about my research and some clinical work I'm also doing. First, I have no disclosures or conflicts of interest. And yes, so like I said, my lab is called the PRISM Lab, Prevention Research in Substance Use and Minority Health. And so really focusing on developmental risk for substance use and related health outcomes, thinking about both protection and risk and the intersection of those among minority populations. And today I'm focusing on Black Americans, which is most of my individual research. My lab looks at minority health broadly. So you'll see on my CV that there's information or studies on there for intersections of race and sexual and gender minority, immigrant populations. So there's a lot of things that are similar across those groups, as well as some culturally specific factors. So just to understand that part of it. And then with my background in clinical psychology, as well as just wanting to make sure whatever I do has true implications that can impact those that we work with, that I do intervention programming to help mitigate risk for substance use, particularly among adolescents, particularly among minority populations. And so with that, I'll show some work that I have done personally in schools and juvenile justice systems, as well as youth serving community centers that focus on justice involved youth, as well as some of my colleagues that are doing work with adults. And also, I guess I have some work coming out with adults for substance use. So I'm going to bridge that gap, starting with just more research and understanding risk resilience, and then transition into some clinical implications. Okay. So really learning objectives is to learn the landscape of alcohol and substance use among Black Americans, particularly youth and young adults, learn some frameworks for conceptualizing substance use risk among this population, and gain awareness in some of the current research I've done in my lab on risk protection of Black youth and young adults related to substance use. And then lastly, like I said, some awareness of substance use treatment and adaptations to treatment when working with this population. So a little bit background. So thinking about substance use and race, compared to white respondents, Black respondents tend to report lower rates of alcohol and tobacco use and higher rates of marijuana use. And these are, why I focus on these three, these are the three most commonly used substances. I should actually probably add an opioid just because that has gained a lot of attention in the last few years, where we do see for some populations actually higher risk of opioid disorder among Black adults, actually, Black male adults. And so, but looking at these three substances, this is 12 and older, using the National Study of Drug Use and Health. I did 2019 because there was a drop in substance use and reports due to COVID. So this was pre-COVID. But you can see that trend of lower rates of alcohol use, pretty much comparable rates of tobacco use, and slightly higher rates of marijuana use. Now, if we're looking at 12 to 17, so a population I do focus on with adolescents, we see a similar trend where actually pretty substantially lower rates of current or past year alcohol use and tobacco use among Black adolescents compared to white adolescents, with comparable rates of marijuana use. Now, if we look at this over time and looking at different types of substance use, we do still generally find this trend. So when a lot of people talk about like alcohol use in particular, which is what I focused on in my graduate program, graduate studies, was this idea that there's maturation, that there's a huge spike in alcohol use through adolescence to your mid-20s. And then once people start having more adult responsibilities and get out of college age, then there's this decline in alcohol use. Well, if you see that red line for up here when we're thinking about alcohol, there is an incline, but it's not as steep or pronounced as what we find for white adults or young adults through this period. Same thing for heavy drinking, that you see this red line, and that's my own makeshift line, so that's why it's not as clean. You see this low rate of use. As well as smoking. But an interesting thing happens with marijuana, where you see in a lot of cases comparable, if not slightly lower rates of marijuana use, sometimes slightly higher. But then this idea, this crossover, where there's actually higher rates of marijuana use, that it keeps inclining into the 30s. Just something to be aware of, that there's these different trends of substance use when we're thinking across groups. Now, what's also interesting, that even at comparable levels of substance use, that there are more problems that have been noted for Black individuals, both youth and adults. Cannabis use was declining, sorry, this is going backwards, declining, sorry, I'm going backwards a little bit. I forgot the slide. So one thing about cannabis use that I wanted to talk about was that this fact that there was this generally kind of, like I said, comparable or lower rates of cannabis use, but this trend actually has really switched over in around the 2013, mid 2000s, where we are now seeing comparable in this first time, like higher rates of cannabis use. So in like the groups that I work with, and a lot of them are Black youth, when I ask them about substance use, alcohol, for many of them says like, no, like we just don't use it. There's a lot of cultural factors around the use of alcohol and concern over what happens if you're seen to be intoxicated. But there's different belief, as well as in the country as a whole, but these, particularly among Black youth that I work with, that cannabis is seen as like you can use it, your parents use it, people in your community use it. And so in 2013 was the first time that there was this nationally finding that there were higher rates of cannabis use among Black youth. So sorry about that, I jumped ahead of myself a little bit. So, but regardless of this fact of comparable use or in sometimes higher use of cannabis, as well as lower use of alcohol and tobacco use among Black Americans, there was pretty consistent evidence of more problems. For alcohol, this was dying and developing liver cirrhosis, higher rates of alcohol rate mortality, alcohol dependence symptoms, as well as a slew of legal social problems from alcohol use. Tobacco use, we actually find also similar evidence of Black Americans reporting fewer cigarettes and starting to smoke later, as we saw in some of those previous slides too, but more likely to die of smoking-related diseases. In cannabis, although we do see, more currently, like 2013, higher rates of cannabis use, even at comparable levels, there's a higher risk of progression to cannabis use disorder, as well as legal consequences that many people are aware of, among disproportionately being arrested and more severe crime or more severe sentences among Black Americans if they are caught using substances. Now, some of this, as I have alluded to, is related to cultural factors. So like with the alcohol use, although, Black youth are generally not as likely to engage in alcohol use, because the norm is not to use, you can have more social problems within your community for using. On the other hand, like cannabis use, although it's normalized in many places with having higher police presence and then within the legal system, more consequences, you can see why some of those environmental factors can be related to some of the social and like legal consequences. But it doesn't really help explain some of the like alcohol dependent symptoms and cirrhosis, liver cirrhosis and things like that. One thing that has been talked about to help understand that is also then thinking about some of the societal factors. So access to treatment, access to medical care that might prevent someone from being able to access care sooner. And then when things progress or having other comorbid conditions, more likely to have negative health complications from substance use. But one other thing that we have been looking at in my lab is the potential of some of these consequences being due to the type of substances, the course of use, and the intersection of the types of substances that are used. So this was work done by one of my graduate students, Devin Banks, that we worked on looking at typology of substance use, and this was among adolescents using the National Study of Drug Use and Health. And what you found was that I circled here is that Black Americans or Black adolescents were more likely to be in the marijuana only category as well as the alcohol and marijuana category. So concurrently using two substances at the same time. And so the idea is that there might be some effect of using particularly alcohol and marijuana that may impact consequences, intoxication, health implications of the use. And we don't know what those are, but again, just looking at the fact that why is this disparity between use and problems? And maybe this will help us understand some of those factors clinically. The second thing to think about also is this trajectory of use. So like I said before, for alcohol, there's this peak generally found and decline. But as you can see for the African Americans, or Black Americans, as I talked about before, is that it wasn't as steep. However, they all came together, those lines, around the 30s, where we could suspect, because there was still a steep decline for the other groups and not as steep for the others, there's what we call a crossover, where there might be actually higher rates of alcohol use among this population compared to other groups. And so there has been studies looking at the idea of crossover effect, indicating this might be something that's happening, particularly in later 30s or later adulthood. So there is some work by Johnson in 1998, looking at the potential of crossover effect at age 55. Watt found this particularly around 35, and Vung Yan also found this effect for alcohol abuse around 50. Related to that also is this intersection of not only age, but also gender as well as income. And so although this study was dated, this sparked my interest of looking at the intersection of these three demographic variables, because as you can see right here, there was this high peak of alcohol related problems as well as alcohol use among particularly Black males that were in the lowest income bracket. So with working with some of my colleagues since 2017 that we published this using the National Study of Drug Use and Health, look to see, is there this idea of a crossover effect for binge drinking among Black individuals compared to white and Hispanic? If we stratify this not only by racial ethnic group, but also looking at it by income as well as by gender. And what we did find was this idea of a crossover effect for the lowest income for both Black males and Black females compared to white and Hispanic males and females. So again, all this to show that yes, there are these just general trends of lower rates of substance use with maybe comparable and sometimes higher rates for cannabis use, but there's some interesting, there's nuances to that are important to look at. One, the typology of use, two, the age range that you're looking at. So if we just said, oh, Black individuals are not engaging in alcohol use, well, that's not really true. One, because it can be those generalized statements, but also understand there's different demographic groups that might be at higher risk as well as race, gender intersections, as well as, more globally understanding the idea of culture and the society historical context that's important to consider of understanding why someone might be not engaging in, let's say, high levels of use, but still experiencing some pretty significant health outcomes from use. And so what this brings me to is that also then understanding theories and models for substance use. And I'm going to focus more on adolescence because that's where a lot of my work lies in. And so in 1995, Ph.D. came up with a risk model for substance use that includes a lot of things that we would think of. We have interpersonal influences, so things inside of a person, self-esteem, aggression, personality, attitudinal, so there are things within schools, there are views, religious views and substance use views, as well as social influences like peers and parents. Now, this was expanded in 2004 by Donovan to include those factors, splitting them up so family and peers were separated, but also looking at communities. So number 6, that drug availability and the behavior and personality are still there on the second and third category. And then what they also split out, which is important, these demographic variables. So understanding that there are different risks based on gender, age, income, race, ethnicity. Now, looking at those more global factors, though, a lot of the work that tried to use this kind of more comprehensive view of risk found that we weren't really accounting for a lot of the risk or prediction and risk for Black Americans. Now, we weren't doing like great overall. So in this model, 64% were accurately classified for the white adolescents, but it was 34, the lowest for the Black adolescents, using, again, these what we will consider universal risk factors for substance use. This is also found in a study by PRISM, again, looking at how much of the variability we're accounting for binge drinking. Again, wasn't great across, but was the lowest for the Black adolescents in this study. And so what this is bringing me to is, again, understanding culture and understanding societal factors that were not included in these models. And so if we look at racial health inequity theory, a lot of this does talk about understanding the social context, understanding the cultural context that can help understand risk and resilience for multiple health outcomes. So there's a cumulative disadvantage theories talking about early advantage or disadvantage can impact someone differential over time. We have the minority stress model that was by Myers that was originally constructed for sexual orientation, but has been used across different minority populations, and really trying to understand how discrimination and victimization, both external, can impact risk, as well as how we can start to internalize that stigma and how that can be another layer of understanding risk for health outcomes. And then there's weathering hypothesis that stress and living in just a society, not even saying that, that individual interaction, like minority stress model of discrimination, but just living in a society where it's racially conscious and stigmatizing, that can disproportionately affect even the physiological health of someone. So in this one, we start looking at how inflammation, how stress hormones, how telomere links, how the body is impacted by just living in this type of culture. And all this, again, is really trying to highlight the point that, yes, there are these different factors that we can say are cross-cultural. So your personality, your parents, your peers, access, norms and policies in society. But what this is really talking about is there also this other level of racism and culture that needs to be incorporated if we're really trying to understand risk, particularly among minority populations, and racism, particularly for racial ethnic minorities. And so this was what the lens I have used when I'm doing my work in graduate school and since that point, and what's really integrated into the PRISM lab that I have here at IU. And so that was the framework I had, and I did a talk last year, and someone said, there also is a published framework that is very similar to what I was talking about. And so I've now included this. So there's a socio-ecological model of racism and anti-racism that really, again, talks about how racism is impacted across levels. And what I want to mention here is racism is a system. Back up for here, the definition that Kamara Jones uses to talk about racism. So it's a system of structuring opportunity and assigning value based on the social interpretation of how one looks, and in this case, race. And because of that, it's a system that then impedes on all levels, that it's not just what we think about as someone does something to me, which is also included in this idea of racism, but it's more than that there's a system approach to it that permeates between policies and access to goods, as well as interpersonal interactions that someone might have. And so I really like the idea that they have started incorporating this into the socio-ecological model, and also giving examples of how this works and how this is exemplified in American culture. So taking all this in, I'm just going to give you some of the research I've done that has incorporated this understanding of racism within a sociocultural framework. So I've worked with colleagues, Gene Brody and his colleagues out in the University of Georgia, and they have a really incredible data set that is 14 plus years old at this point. The data I was using had youth, Black youth and their families that were recruited in 2002 when they were 11, and they followed them annually for this data set until they were 21, which is remarkable to be able to follow people and families for that long. Now, these were all youth in rural South and Georgia. So there is, something there to think about generalizability, but it's a nice data set to be able to answer some of these questions. And so what I wanted to look at is like, okay, thinking about this idea, we have these sociocultural factors that we think are cross-cultural, but data and research in the past has shown that they're not as predictive, fully predictive for Black youth. And then this work with understanding racism and how that hasn't been included in those models. Does adding racism within these models help increase the predictability in understanding risk for substance use, particularly among Black youth? And so this is done a comparison because these are all Black youth. But again, looking at those different domains. So we have family, we have social risk that has parent-peer conflict, parent social support, substance use of peers. So those are combined together, kind of thinking about that first model by Ph.D. We have attitudinal risks, so thinking about views, goal setting, religiosity is in there, school engagement, and then interpersonal, so that's the externalizing behavior, self-esteem, depression, and then I have a cultural risk index that was, honestly, it was just racial discrimination or racism added to the model. And so the goal here was to see if we can predict initiation of substance use among the youth in this study based on those domains. And so we separated for cigarette, alcohol, and marijuana use initiation across those age range. So those that at age 11 had not initiated, and then who did initiate by the end. So this was just logistic of initiation by the time completion. And what you see here is that of each substance that racial discrimination predicted was a consistent predicted across all three substances. You'll see there's some differences, like with interpersonal also being predictive of cigarette use and some SES being risk or actually a protective factor. But as you can see, discrimination was a significant predictor. And what did I take from this study? Really is want to show, okay, that yes, these other domains are important, but when we're thinking about risk, it may be particularly important to understand the impact of racism and racial discrimination on substance use initiation among Black youth. And then taking it further, if we do have solid evidence, which there's a whole bunch of evidence at this point showing discrimination is important, this was one of the first studies to show is important even above and beyond or accounting for these other risk factors. And then how do we incorporate them into clinical interventions as well as like for assessments that we use for help understanding risk for substance use. And so one of the programs that Dr. Brody actually does is called the Strong African American Family Program, and they do address discrimination within that intervention. Now, like I said before, that discrimination or racism is a system, and there's different levels to it. And so, although a lot of our focus, even that study was on that person-mediated, the direct kind of interactions that a person has, that there are some nuances within that I have also looked at. And so, one of them is this idea of racial microaggressions. And racial microaggressions are a little bit different than just a day-to-day interaction that people have, which again is also included, but it's more comprehensive than that. The microaggressions are brief, everyday exchanges that send demeaning messages to the target group. Many times they are subtle and indirect, so they can be really difficult for someone to recognize they're doing. And sometimes also can be confusing and difficult for the person that's the recipient of a racial microaggression because they're so subtle and sometimes indirect, you have to be like, I'm bothered by that, but why am I bothered? And so there's more cognitive work to get at, like, what was the assumption that was being made there, and why is the statement sending off a message that I am unwelcome, that I'm unsafe, that I'm being alienated or isolated. And so sometimes it's difficult for someone to comprehend racial microaggressions. And I have this video that I like to play, and it also comes from kids, to be able to understand how some of these microaggressions are experienced.
Oh, you're so pretty for a black girl.
Oh, she has a Jew nose.
Oh, your hair would look so good if it was straight.
Jews are so cheap. Why are you so cheap?
Do you speak good English?
How are you an Iraqi Jew?
I think the person saying microaggression kind of doesn't really think about it.
This person who said it was my friend, and like I was astonished that they would like say something like that.
You don't want to make a big deal about it, but then it's also like you just said something that offended me, so I feel like I should speak up.
Because they're micro, because they're very subtle, they're small, you feel like you don't have a reason to be upset. You're overreacting, and people even can make you feel that way when you bring it up.
They're like, oh, you can't take a joke.
You're making too big of a deal of this. Why are you overreacting?
Don't take it so seriously. It was just a joke. Chill out.
Say like, oh no, I actually love black people. I love people of color. Like they try to just minimize the situation.
If someone feels hurt by a microaggression, it shouldn't just be pushed to the side.
It definitely has negative impacts and like leads to people disliking who they actually are.
Those kinds of subtle offensive comments can build up over time, and they can have like a deep psychological effect, and you know, they can make you feel bad, and they can make you doubt yourself.
We try to just use jokes to like make things less awkward or like ease social experiences, but it is important because you need to like be aware of what you're saying and like who you're speaking to.
Think of what you say and how it can affect the person you're saying it to.
So I really like that one because it's coming from kids, and a lot of good examples of how microaggressions are experienced. But if you saw at the bottom, it also talks about how common they are. So in one study that was published in the Cultural Diversity and Ethnic Minorities Psychology Journal, found that in 90 days, students that they had them do journal, like a daily diary, was 291 times of experiencing microaggressions over the course of 90 days. So very common, and can have a very strong impact on how people view themselves, as well as that the chronicity of it happening, and the cognitive load it takes to deal with microaggressions. And so again, this is another nuance to it. Is not saying like someone came to me and called me a racial slur, but these more subtle interactions. And so we were looking at that, of the fact of racial microaggressions. This was among college students. But again, trying to account like how does this specific type of experience relate to substance use, accounting for some other types of trauma or stressors that we know also, again, cross-culturally also impact risk. So this was looking at trauma. So this was the looking at everyday trauma, or not every day, but it was a trauma scale. And that includes everything from like getting into a car accident, divorce, breaking up with a girlfriend, boyfriend, partner, as well as like sexual assault. So it's very broad of like stressors. And then also had racial microaggressions in the model. And as you can see for alcohol use, that it predicted above the other factors in the model and covariates, as well as for cannabis use. So again, these are just studies to try to not just understand, which a lot of work does, of just the prevalence of these type of culturally specific stressors, particularly for Black youth and young adults, but how do they fit into these other models or our understanding of substance use risk or health, with all these other factors that have been studied for, for quite a while. And so these models are saying, yeah, those other factors are important, some of them more than others, but also understanding racism and racial microaggressions are also important, and also adding important variance in understanding risk. So all that to say that these two, again, are focusing on this kind of interpersonal relational factor. There's a lot of work now with NIDA giving our NIH getting money for looking at systems, and so understanding policies and procedures and how those are impacting risk, as well as other institutional community factors, as well as going the other way and looking at like individual or interpersonal. So how one like sees themselves, and we call that like internalized racism. And so one study that I'm currently working on that is looking at those things is a study that was funded by the National Institute of Health, the National Institute of Drug Abuse, actually, and where I have been following youth and young adults over the course of a year, and I'm asking them questions about microaggressions, macroaggressions, vicarious racism, as well as, just trying to understand the different ways in which racism might be experienced, as well as traumas and other stressors. But going a little step further, as I talked about before, that weathering hypothesis, talking about how living in a race-based society can impact health, as well as getting underneath the skin. And so this study is unique, is that we're looking at how stressors impact that. And so we're looking at inflammation markers, as well as like stress hormones among these individuals over the course of a year with three time points. So I'm really excited. I'm coming to the end of this data collection. I'm now getting their 12-month assessments, and so hopefully have some information on, again, how this process is working among the youth and young adults that are in my study. So I just want to switch over now. I've talked about some of the research that we've done in our lab, and I guess more broadly is understanding the kind of landscape of substance use. And so I want to switch over to that other side of thinking about treatment implications and interventions for substance use, particularly among Black Americans. So we know in general that across racial ethnic groups, there's generally a comparable likelihood of seeking out substance use treatment. However, when we're looking at completion or satisfaction or just engagement in treatment, that there's lower rates among Black Americans. So this was data from the treatment episode data set for substance use. As you can see, and like I said, for meetings, there's not great rates across the board. So about 50% of people are, completing treatment, but the rate is lower among Black Americans. This is also similar for older adults, where older Black Americans were 37% less likely to complete treatment than their white older adult counterparts. You can see this also across substance type. Now, there is some variability, but in general, this is Black versus Hispanic, that you're seeing lower completion rates among Black Americans for outpatient treatment. And so the question, okay, what's going on? Similar to what I was talking about for just substance use, that there are cultural and environmental norms and factors that are important to consider. And so for this one too, that have been highlighted in the literature is stigma, and then my common factor here, racism. So first with stigma, this is really just describing the process, the nature of how people feel, perceive, as well as behaviors regarding health behaviors. In this case, we're going to talk about specifically, or health conditions, specifically substance use. So what does this look like? This could be self-stigma of having negative messages about my beliefs about engaging in treatment, or my ability to complete treatment, other people's views about whether or not you should be in treatment, or what it is like to have a substance use disorder. This also comes from the healthcare system itself as well. So there are stereotypes and prejudice regarding people with substance use disorder compared to other conditions. And those are the intersections then of like race as well as substance use. So a Black substance user might be treated differently than a white substance user or an Asian substance user. And then lastly, there's also structural stigma. Are there structures in place of policies and procedures that decrease the likelihood of being able to engage as well as complete therapy? Are there stipulations that are in place that make it more difficult? On top, so there's a lot of work of being able to just decrease stigma for engaging in substance use treatment, decrease the stigma of the healthcare system and procedures that are in place. So for example, like for clinical implications, if I say I'm going to cancel your appointment if you're more than 15 minutes late for an appointment, on the surface seems great, but what if a person has to take 5 city buses to get to you, and they're going to be late because there's structures in place that there's not, ability for them to get to your facility quickly? Then there's the barriers within the policies and procedures, right, they're impeding someone's ability to be able to get treatment that they need. So again, so decrease as well as many interpersonal or biases that people might have about certain groups. So anyway, so you can decrease the stigma individually as well as within the healthcare system and within providers and within the structure for obtaining services. We also can make them available, make them accessible in a place where people feel safe and supported. And so one of those places, particularly for Black individuals, is the Black church. And so one of my dear friends and colleagues has done a really great work of being able to incorporate substance use treatment within the Black church. Why is this important? Because this is the place where many Black Americans go to for support, for refuge, and while there also are already in place other social support systems for individuals. So my friend Ayana Jordan, Dr. Jordan, has been doing this work of the feasibility of providing substance use treatment within the Black church. And this is just some data that she has done. This in the Northeast by New Haven, where demographically, right, that only 8% were employed. So again, this is the population that maybe already has difficulty having access to care. And then also over half of them met criteria for severe substance use disorder. So likely not in treatment, not employed. So in this case, maybe having difficulty also with healthcare. And they did engage the intervention within the Black church. This was a pilot study, but 39 out of 40 of them completed the study and averaged 6.8 sessions, which is just remarkable for any treatment that you have this high of completion rate and engagement. So, and then 4 point out of a scale of 5 of very dissatisfied to very satisfied, there was a rating of 4.5 of how satisfied they were with the services they received. So again, making it accessible in a place where people feel accepted and in a safe place. And this is actually one of the things that comes up when people are talking about, particularly to minority individuals, like, why might you not be engaging in treatment? And this is across the board, not just substance use, but just clinical treatment in general. And one of the things is not feeling understood, not feeling that cultural factors are really taken into consideration, and understanding how like racism or microaggressions might be impacting why someone might be engaging in substance use, why maybe it might be difficult for them to stop, stressors that they're having that might be impeding on the ability to reach their goals as related to substance use. And again, I talk about policies and procedures. So it's not just someone saying something to me, but there are also systems in place that are making it difficult or causing barriers or stressors for sobriety or decreasing use. So now I'm going to shift to some work that I have been doing with adolescents related to this, and how can we incorporate culture within the work that we're doing. So I have kind of a long track of using dialectical behavioral therapy for adolescents in both clinical and community settings. And what's great about this is that it really teaches about kind of underlying factors, kind of universal factors that are important for understanding engagement in substances, as well as a number of health complications or problems among both adolescents and adults. And so trying to decrease access and having a safe place, what we have been doing is a 9-week or now 10-week program of doing DBT skills in a group setting for like 6 to 8 kiddos. We do that in schools, and I'll talk about, we've now expanded this to some community centers where we work on them identifying goals that they have, personal and academic, and then teaching them the skills of DBT, which are mindfulness. So being able to focus on one thing in the moment, being present, emotion regulation, how to manage your emotions, distress tolerance, how to be able to sit with an emotion without making it worse, and then interpersonal effectiveness, how to communicate what you need to other people. And the goal is that we can teach these skills that will decrease risk for substance use as well as related health outcomes, can increase self-esteem, decrease depression, anxiety. And so this is just some of the data we have from 3 years where we did this in a few high schools in Indianapolis. We had very good retention. So about 84% of kids that started the intervention finished it. So really good response rate there of engagement and completion. Those that left were generally because they moved schools or something happened. It wasn't that they just decided not to be in the intervention. We do have a pretty good spread of our fairly high diverse groups. So 60% Black, 13% multiracial, 9% other, 30% Hispanic. So some of the outcomes, so we can compare those that completed the intervention compared to those in the control group, which is just the health curriculum that was provided in the schools, and we matched them on like a similar baseline factors and looked at pre-post of substance use, likelihood and engagement, as well as other risk-taking behaviors. And so you can see that there is a 18% or 19% decline in substance use post-treatment. And then we had a 1 month follow-up that also had a decrease. Now, what you see increase for controls, I mean, that's normal. We say that in adolescence, there is generally a spike in substance use. So, or not spike, you know, gradual increase as people are going through adolescence. So, so we're seeing that the program is helpful in decreasing substance use, as well as risk-taking behavior. So all that's great. But one thing with here is that, you know, we're focusing on kind of, I mean, basic skills that we think are culturally, cross-culturally valid. And so the question is like, well, what happens if we actually do expand this thinking about cultural adaptations to talk about things that are particularly relevant among Black youth? And as we saw, like 60% of the youth in this study were Black, and then you also have, you know, others that were racial ethnic minorities. And so what we have done is added a session to explicitly talk about discrimination and bullying as both an observer and a victim. And so we talk about discrimination across the board. So it's not just race specific, but based on any identity, what is it like to experience it? Like just acknowledging, like, hey, this happens. So like, what are some ways we can manage and deal with it if we are experiencing it, as well as how do we speak up and do something if it's safe, if we see it happening to other people. Also including more information on inclusive language throughout and giving more explicit examples about discrimination and bullying throughout the curriculum. And so we're now in the process of seeing how that addition changes the impact of the intervention, as well as just getting some feedback from students as whether they liked it or not. Expanding it to is outside the schools is that right now we're implementing a pilot of the Going for Goals program in Voices, which is a day reporting program for youth that are mostly male, all live below the poverty line. And at least those in my group are also involved in juvenile justice. So it's day reporting, so they come to Voices rather than going to the schools. And so all of the youth are, like I said, involved in juvenile justice. So again, we're seeing that intersection too. And when I'm giving examples like what makes you scared, they say like the police. And so we just have these discussions. Okay, well, how do we incorporate this information and what we're learning with the experiences that you have had and moving forward that you might have in the future? Now expanding outside of adolescence into adults, or sorry, still adolescents, but moving outside of Going for Goals is a study that I'm working on with Dr. Alsma and Tanisha Riley, where we are talking to parents and youth of color about their experiences within juvenile justice, specifically treatment for substance use. So like I said, that there is a gap between access to treatment and then actually like engagement and retention. And we have actually found this in this data as well. So we have what we call a cascade of care, where we can see how many kids were identified as having a substance use issue or screened, and then were they referred? And if those were referred, how many of those actually went to their first session? Of those who went to the first session, how many of those completed their intervention or treatment? And so you can see across the cascade. And, you know, it was actually still shocking to me that when we looked at this across the counties that we were working with, and there's 3 specifically that we were looking at, there were no kids of color. Now the numbers are still low that were referred that started treatment. And so there's a breakthrough. It's like, so we need to really know what's happening. If they're referred, why are they not engaging in treatment? And that's of youth of color. And there's some counties where those are engaging, but again, like what we've seen the data, the drop is significant of completing treatment. So it's happening across the board and happening in juvenile justice. And so that was aim one. Aim two is to characterize what are barriers or motive factors for getting through this process. And so we're talking to community health, mental health workers, as well as those involved in JJ, of what's happening within the system level, and then having individual conversations with parents and their kids to see, like, hey, were you referred? Like, what happened during that process? Did you engage in treatment? If you did not, like, why not? So trying to understand both quantitatively with the data, but qualitatively with interviews, what might be happening here. Now, with also Black adults, I'm working with Christina Lee and Virgil Gregory and what this all this is also taking on, this is what we call community-based participatory research, where we're engaging people within the community within that process. So we have been talking to different traditional and non-traditional settings where people are engaged in substance use care, and talking to both the system, so the organizations and the staff, about what's happening, what do you see, what's helpful, what's not helpful, as well as talking to individuals that are seeking care or not seeking care, of understanding, like, hey, what are you seeing as the barriers or reasons why you are engaging or not engaging? Now, I have a sense that, there are these cultural factors that are not being incorporated that are important, but again, getting that information directly from the people that are working with substance use, Black adults with substance use, as well as talking to Black adults themselves, are really important and should be incorporated into the research. And then lastly, I just want to highlight this work because I think it's just so amazing. So this is another colleague that is kind of doing the same thing, but looking at cannabis use specifically among Black youth that are involved in juvenile justice. And so there was already an intervention that was used for cannabis youth treatment. And what she was finding with her clinical work was that a lot of the Black youth she was working with would say to her, like, this is great, but this is really not accounting for the experiences that I've had. And so she was able to get a K award through NIH to really take this intervention that does have evidence, but understand how can we incorporate racism more directly within the intervention, and how that again impacts the success and the retention of youth of color, particularly in substance use treatment. So again, all this idea is being able to incorporate what we're learning in research and what we're seeing into actual application with working in communities and clinical settings, and also hopefully to be able to impact policy and procedures. And I just want to be remiss that, talk about racism and these stressors, which are also very important, but also understand there's resilience, there are protective factors that are also important to consider. I don't have a lot of time to go into this, but we have a whole other segment of the research that we do that looks at racial and ethnic identity and ethnic socialization, how that process works, and how that also can impact the just resilience and just the self-esteem and depression, anxiety, substance use among Black youth and adults, and how that intersects with experiences of racism and discrimination, as well as other stressors. So that is generally included in a lot of our models, as well as like Gene Brody and his intervention includes this idea of ethnic socialization and racial identity development in the interventions. So I wanted to just take a step back and thank the different colleagues that I've worked with in my PRISM labs, my graduate students. Some of them are on internship right now, as well as the collaborators I have with University of Georgia, as well as the Adolescent Behavioral Health Research Program here at IU School of Medicine, and the funding that I received from NIH and the IU Grand Challenge. It's a picture of my lab.